Hello, everyone. How are you guys? Long time no see. Am I audible?
Yes, sir, you're audible. Yes.
Yes, right. Sir. Okay. So shall we start? Not sure about it.
Sure, sir. Yes.
Right. Yes, sir. Yeah, as long as you can hear me well. Again, hello. How are you guys? Long time no see. I hope you guys are doing well. I'm pretty sure your guys are doing well already. Anyway, now in this window period before the exams, results come after the exam. I would like to call it the window period. I'm sure a lot of people are anxious as to how they've done and what's going to happen. The results are due very soon. So welcome to this special session of Marrow, where we try to recall and answer the questions which has been asked in the recent exam, NEET SS. So before we go into this, I'm sure you've already undergone this recall with multiple other institutes already putting up the recall questions, which makes almost similar questions with similar options and pretty much the same answers. So along with that, let us try to introspect also and to see what we could have done better or what you guys, everybody could have done better. And what are the takeoffs from this exam? And basically the one question you guys need to ask to everybody needs to ask themselves is, how can you be better? Because that is a question which is going to help you, however successful you are, how old or how young you are. So let us try to answer those questions with starting with this question. So let us go on to the first question. The first question is basically a patient was incidentally found to have anti-HCV antibodies. Testing showed certain amount of RNA copies, around 234 units per liter. LFT is normal. What is the treatment modality that is preferred for these patients? So this specific questions can be actually pretty much summed up into a new patient, incidentally detected patient to have HCV positivity without no evidence of liver cell dysfunction. So he doesn't have cirrhosis, he has no issues, just randomly detected HCV positive with the RNA copies of 234. Now what do you do? Well, unlike HPSAG, hepatitis B, HCV is whenever you get it, you try to treat it. You treat it. And with the current treatments, the curative rate is around 95 to 99%. That's quite big. So what do you do here? Here, the answer is directly acting antiviral. You have to reassure the patient, obviously, but yeah, the answer is directly acting antiviral. You can, if you have the genotype, you can add sofosbuvir, daclitaxel, or ledipasvir, depending on what is available in India. If you don't have the genotype, you have the pangenotypic regimen, which is valproatasvir and sofosbuvir. You have to give it for 3 months. After the end of 1 month, you have to check for the RNA levels, and then after 3 months end of treatment, you have to see for response, and then sustain virologic response. So, which is what already been taught in my previous classes, where there's no cirrhosis, no prior therapy for HCV, now HCV positivity. What do you do? Now, glycoprevir and prebrentasvir is what ASLD guidelines give, but we don't have that. In our setting in India, it's sofosbuvir and valproatasvir pangenotypic for 12 weeks. And sustained virological response you can check after 12 weeks of therapy. So the next question is, what is not a part of simplified scoring system of autoimmune hepatitis? You've got multiple options, out of which the obvious answer is serum bilirubin. Why? Autoimmune hepatitis scoring system, there are two kinds of scoring system, you're pretty sure of it. Now in this scoring system, this is for the diagnosis purpose of it. So this is a for the original scoring system for the diagnosis of autoimmune hepatitis and simplified scoring for the diagnosis of autoimmune hepatitis. So in either of them, there is no bilirubin. Why? For diagnosis of a liver disease, you do not require a bilirubin, because for any kind of liver disease, bilirubin goes up. That limits the specificity of bilirubin. So for diagnostic purpose, very few situations require bilirubin levels actually. And for prognostication, on the other hand, INR and bilirubin are very important, because that is what gives you the prognosis of the disease. But for almost all diagnosis of liver disease, bilirubin is something which we don't ask for. So for a simplified scoring system, you have to look for autoantibodies, immunoglobulin levels, histological features, absence of viral disease hepatitis. So out of that, definitive diagnosis is for more than 7, a probable diagnosis for 6. Now, The other one, the revised original scoring system, is pretty much kept reserved for people who have research in situ. So when you are doing research, you better get the original scoring system. Personally, when I treat a patient, I try to fit everything into the original scoring system, with obviously keeping simplified scoring system with us. As long as you have biopsy, you're pretty much comfortable. So the next question, hepatitis B patient on lymphoma with lymphoma on rituximab. What is the prophylaxis duration? Now this has been taught to you very clearly. Basically, a person with hepatitis B, depending on medications he is going to take, can be, the reactivation of hepatitis B can be classified as low, moderate, and high. And rituximab literally comes down to the high spectrum, because the chance of reactivation on rituximab is more than 10%. Now that is a very high this thing, because basically what means by reactivation is the control of the body over the virus is just completely taken out, and the virus proliferates. And once virus starts proliferating, it reaches an extraordinary amount of levels from where the body tries to suppress it, and thus takes care of all the good hepatocytes, all the infected hepatocytes, and you'll end up having liver failure and death. I must have spoken to you about this before also. There are we 1, 2, 3 patients have died because of reactivation. Actually, recently I have come across one patient who reactivated, but not on rituximab, but on cyclophosphamide. But she did not have a very bad reactivation. It was I'm always very scary about hepatitis B reactivation on these immunosuppressive agents. So in this specific question, hepatitis B patient with lymphoma and rituximab, prophylaxis duration is 6 to 12 months. Actually, if it is only rituximab, they say give it for a year, but they go on to also say that it can be for 6 to 12 months as well. So highest risk is for anti-CD20 rituximab, and high-dose glucocorticoids, anthracycline, TNF-alpha inhibitors, methotrexate, azathioprine also have it. So this is the table from Schlesinger, where anti-CD20 rituximab is a high risk of reactivation, and which is basically more than 10% chance of it. So antivirals has to be started at least prior to therapy, preferably 1 week before, giving immunosuppressants, and 12 months for retox and 6 months for others. Low risk, you can give it only for 3 months after therapy or even now. So prophylaxis at least for 6 months after discontinuation of immunosuppressive agency, or 12 months for B cell depleting, which is basically rituximab. So if 6 to 12 months is the option, you can go for that. If 12 months is an option, please go for that, because that is the rituximab, since they have asked rituximab specifically. We go on to the next question, where little score is used to assess the steroid responsiveness in which of the following conditions. Same thing which has been taught again is basically alcoholic hepatitis. Now, alcoholic hepatitis is actually a very severe disease if it goes into the severe spectrum. Now, I have taught you how to calculate the discriminant function. It's basically delta PT, that is the control PT, the patient's PT minus the control PT into 4.6 plus bilirubin. So based on that, if the discriminant function is more than 32, you end up having severe alcoholic hepatitis. Severe alcoholic hepatitis is quite bad, because the mortality rate is quite high. It can range up to 50%. So 1 in 2 patients die of severe alcoholic hepatitis. Now, little score is basically proposed for predicting mortality who have been treated with corticosteroids. Steroids obviously is immunosuppressants, and when you have severe alcoholic hepatitis where your immune system is already compromised, selecting patients for corticosteroids is an important issue. So there are a lot of things. For example, if you have GI infections, if you have ascites, if you have GI bleed, if you have severe renal disease, you do not give steroids. So based on that, you should not start steroids on certain group of patients. But what are the groups of patients whom you can continue steroids or you can stop steroids? There, little score comes into the picture after 1 week. So you do a bilirubin in the beginning baseline and bilirubin at day 7. And then we figure out the little model where, after combining all 6 variables, if the score is more than 0.5, then you just stop this corticosteroids. So you get 1 week of corticosteroids and you do not follow it up for the next 3 or 4 weeks. If there is a response, if it's a complete response, please go for it. If there is something called as complete and a partial response and a null response. Now, that is not there in a lot of places. Basically, it's either 0.45 or less than 0.45. Less than 0.45, good response. More than 0.5, bad response. But in British guidelines, they go on to a complete, partial, or null response. So mortality is 40 to 50%. So how do you manage severe alcoholic hepatitis as per matrix discriminant function? So that is basically, like I just mentioned, steroids. Now there's a trial done in I think 2013 called STOPA trial, 2010 I think. STOPA trial, where they took around 1,000 patients with alcoholic hepatitis and they figured this out. So this is the graph which has been already told to you in the class, where matrix discriminant function is more than 32 or MEL score more than 20. You begin prednisolone 40 mg per day. You do a little score at 7 days. If it is less than 0.45, complete 4 weeks of prednisolone and taper over of 2 weeks. If it is more than 0.45, stop. Think about liver transplant and the other things actually. Now, in this clinical, why they mentioned clinical trials, there are positive trials with respect to fecal microbiota transplantation and positive trial with respect to the TNF inhibitors as well. So the next question on a GI question, the motilin receptors agonist used in GI disorders is erythromycin, or the macrolides go and act on the motilin receptor, which can increase the motility of the gut. Now this is used. This is actually used in a clinical setting in India as well, where you have an upper GI bleed, and if you want to, if you don't want to give metoclopramide, you can give erythromycin, and then you can plan for an endoscopy. So that will increase the gastric emptying, and thus what will happen is you'll be able to visualize your mucosa better. The next question is a male patient with a history of CLD, hemoglobin 19. Platelets of 90,000 present with abdominal pain, high sag, hypertenositis. Rest everything is normal. What is the diagnosis? Now, this is the question. This is pretty much a very basic conceptual question. Now, in a CLD, we have been taught that there is hypersplenism, and thus there will be low platelets and pancytopenia. But what do you, when you get a patient with CLD with normal platelets or normal hemoglobin, or in this case, high hemoglobin, your antenna should go up. This is not let me tell you that this is not only the case in situations where MCQs are involved. This is a real life scenario, because there are a lot of times, this actually, I learned it the hard way. I learned this specific thing the hard way, but because of that, I'm not going to forget about it. Patient came, it was a polycythemia rubra vera. She had hepatic venous thrombosis causing Budd-Chiari syndrome. And because of my ignorance, luckily it was taken care by my seniors' oversight, and they could manage to start anticoagulation soon. Because once in any vascular disease, if you don't intervene with anticoagulation or thrombolysis immediately, that part is gone. So that part of the liver or that part of whichever organ is it is gone. So whenever you suspect a thrombosis, you have to be very, very fast and very quick to get the diagnosis. So in any CLD case, if you see any CLD case, you see no pancytopenia, antenna up, get the vascular, get that, you're going to have a thrombus somewhere, especially, or you can also see CLD patients, massive spleen. You should have pancytopenia, but there's no pancytopenia seen. Okay, now the next thing, high sag hypertenositis. Now, high sag hypertenositis is obviously not secondary to the liver, it is suprahepatic. So in suprahepatic, there's only one of these four which is suprahepatic, which is Budd-Chiari. So just based on sag, we can diagnose this. More than 0.11 high sag ascites, then you see the ascitic fluid protein. High sag low protein, high sag high protein. High sag low protein is our cirrhosis, METS late Budd-Chiari syndrome. Here what I want to say is a late Budd-Chiari syndrome presents and is treated as a decompensated CLD. That's all that is there to it. So that is the reason why we need to pick this patient up fast. This has to be treated fast, because once you delay the treatment, once the thrombus is formed and then anticoagulation is not going to work, that is the end of that. And you will have to treat the patient just like another chronic liver disease. Whereas if you figure out Budd-Chiari syndrome early, and because by multiple hepatic venous, you can get a scan, CT scan would pick up, MR venogram would pick up, anything will get up we pick up this Budd-Chiari syndrome. And whichever, if you look at it, all of them are suprahepatic and all of them can be treated, except the sinusoidal obstruction syndrome, which is quite difficult to treat. So high SAG, high protein, think of suprahepatic. The next question, oh, patient with a recurrent history of recurrent acute pancreatitis, ERCP's image is given, what is the likely diagnosis? Now, it is very unlikely that it can be Ascaris. It can, in the situation, recurrent acute pancreatitis Ascaris is very good thing, but then when you have an ERCP image, Ascaris looks like more like a tube. So it is not like a filling defect per se. So basically you will have a, let's say, let's see if I can draw it. Okay. If this is the bile duct, Ascaris will look just like this. That is how Ascaris will look. So it will be a linear hypodense structure which you will see on a cholangiogram. Whereas if you feel that it is a cholelithiasis or stones in the bile duct, it will be just like a stone in the bile duct. So they'll have stone like this. So there will be filling defect, as I'm going to show you here. Just a second. Yeah. So if this, you can see this is the ERCP. This is the ERCP scope that is there. This is the ERCP scope that is there. See, you can see the stones. See, so clearly you can see the filling defect. Here also you can see the filling defect. Now, if it is Ascaris, obviously there will no segmentation will be happen. It will be a linear tubular structure that is there. Now the next question is pneumobilia. Now, pneumobilia is something that can happen. But here at your level, it has to be choroidocolia. There's no way it is pneumobilia, because pneumobilia is a dynamic disorder, dynamic cholangiogram features. If you get a CT done, you can see air within the bile duct. That is what is called pneumobilia. But when you do a cholangiogram, sometimes air bubble also goes in, and that air bubbles can look like a choroidocolithiasis. But when you talk about pneumobilia per se, that is basically a CT finding or a imaging or a ultrasound finding where you have air in the intrahepatic bile ducts. So this is clearly a stone disease. So this is another stone disease where you can see the basket that is there. So basket has held on to the stone that is there has been held by the basket, and we'll pull the basket out with the stone. You can crush the stones and pull the basket. So next question, drug likely to cause hepatotoxicity in children less than 3 years. Okay, let me just go back to the previous question. No, this question is something which I would consider as a very tough question, because unless and until you're exposed to an ERCP setting where you actually see a cholangiogram and or you actually look at the textbook cholangiogram and you understand that these are stones, or somebody tells you that these are stones, it is difficult to answer this question. When you go on to the other side, when you go on to the gastroenterology side, then it becomes very easy, because this is pretty much there all the time. But on this side where you guys are, this becomes a tough question. Now for this question answering, you will have to go for the extra, like around 20% effort there. So the next question is, drug more likely to cause hepatotoxicity in children less than 2 years than adults. Now, in my drug-induced liver injury classes, I have mentioned about valproate, and the first line of valproate is the most common with respect to children. Now, this you can't do anything about it. This is the slide from. This is the exact same slides that is picked up from my class in Marrow. This is the first, pretty much the first line that is there, and it is the most common cause with respect to anti-epileptic drugs. Now, how do you remember this is something very difficult. It's quite difficult. Now, this is good. This is an extremely difficult question where either you have to be very lucky about it, or you have to have a complete hold of a drug-induced liver injury, which is not a small feat. Drug-induced liver injury spans textbooks. So that's all that it's been mentioned. If you have got it, you've got it. But don't worry about it. It's okay. The next question is, patient with pneumonia treated with common antibiotic after a while developed hepatitis, and there is a cholestatic pattern. Now, which of the drug is predisposed to it? Now, this is a question which is not, I mean, both of them are DILI questions. Both of them are drug-induced liver injury questions. One was valproate, one was cholestatic hepatitis. Now, in this situation, what I would say is this is not that tough a question because it is answers coamoxiclav. The reason why coamoxiclav is it is a common antibiotic and we all use it on a daily basis. So this situation, this thing we have to remember, and I think I've mentioned it multiple times. It is mix of primarily cholestatic injury. It is the amoxicillin is toxic, but it's potentiated by clavulanic acid. So if it is taken, the clavulanic acid is taken away, amoxicillin hepatotoxicity is minimal. It makes this not that tough a question. This becomes a 20% within the 20%. So if you look at questions, around 75 to 80% of questions are simple. 20% will be tough, and rest 1 to 2% will be extremely tough, which is not, which is very tough. Now this question will fall onto the 20% of it. Now a non-cirrhotic present with hepatocellular carcinoma. The size of the masses are less than 3 centimeters, and there are 3 masses. What is the treatment modality? Now let's see. It's a cirrhotic patients. So resection is not possible. Why is resection not possible? Because a cirrhotic patient has portal hypertension. If you resect a part of the liver, the patient will go into liver failure. So why don't you resect? I don't know whether I mentioned. Why don't we resect these patients? Because even though the liver is cirrhotic, there are patches of liver in the cirrhotic liver which are functional and which are the actual functioning masses of the liver. So when you take them out, when you actually resect these part of the liver, there will be multiple functional hepatocytes which are actively protecting the body or whatever function of the liver they are doing. That also gets taken away. So you resect these patients in cirrhotic, you are done. You end up having liver failure. So that is why resection is absolute no-no in cirrhotics. Now cryotherapy, as of now, we don't have any cryotherapy for HCC. Now we are left with 2 things. One is liver transplant and chemoembolization. Now, transplant is the ideal modality in this case. How? Because it will come into the early stage in BCLC classification where a single or 3 nodules less than or equal to 3 centimeters. If it's a single nodule, if there is a, if the single nodule, if there is no problem with portal pressure and the portal pressure is normal, bilirubin is normal, that means there's no cirrhosis, you can resect. If you have a doubtful of portal hypertension, you have to go for a transplantation. So this is pretty clear. 3 centimeters, less than 3 lesions, straight away go for transplantation and it becomes a curative treatment. This has been explained multiple times in the classes and the questions. Now, a patient is a non-alcoholic. What is the deformity? Now, this I don't think any online classes requires to teach. This is there in our wards, left, right, and center. Any ward you go through, you will see Dupuytren's contracture. If it is an alcoholic liver, obviously medicine, you will get it. Not much discussion on that. Now, true statement about ALT and AST. And the true statement is ALT is more specific than ALT because ALT is from the liver, AST is from multiple organs. ALT, L is from the liver, L is specific, L for liver. So the aminotransferases, like I've mentioned, so you've got AST and ALT. So like I've mentioned before also, AST is from the mitochondria and cytosol, or ALT is in the cytosol. And ALT predominantly is in the liver. The AST is cleared by reticuloendothelial system as well as the liver, where ALT is clearly by the liver. So basically, that is the answer to that. I don't think much into nothing. So the next question. A patient presents with history of recurrent abdominal pain, diarrhea, weight loss. Biopsy demonstrated non-caseating granuloma and skip lesions. What is the diagnosis? This is a straightforward question. This is a straightforward question where you can mark Crohn's disease as the diagnosis. Nothing much to tell about it. It is not UC. Why is it not UC? Because patients present with diarrhea and weight loss. UC will present with diarrhea and weight loss, but UC will have bleeding PR as well. Now, abdominal TB, very much possibility, but the question itself has said that there is a non-caseating granuloma. So abdominal TB is out of it. Celiac disease, there's no mention about non-case granuloma at all in celiac disease. So you can actually, this question can be actually just without knowing much about these 4 diseases, you can actually take out the options and then get the Crohn's disease as the answer. So next question is, in a patient who's undergone ileal resection, which vitamin deficiency can be expected? It is obviously B12. Why? Because the absorption happens in B12. Now this one, true statement regarding parenteral nutrition. LFT and triglyceride monitoring to be done. Target blood glucose is to be 100 to 180 milligrams per deciliter. Initial dextrose is up to be 200 to 50 grams per day, and lipids start in second day. Now with respect to TPN, what we have to understand is how much ever possible we avoid TPN. Now for TPN it can be used in so many situations where you have pancreatitis, so many situations you can do TPN. Now, when you talk about TPN, what do you need to do? So it is basically, there are 2-in-1 and 3-in-1 TPN. 2-in-1 TPN is basically without lipids. So you take the carbohydrates and proteins and give, or carbohydrates, proteins and lipids, making 3-in-1. Now, what you have to understand is the TPN is actually measured and given. So basically, you have to understand the caloric requirements of the patient. Depending on the disease of the patient, you can understand the caloric requirements of the patient, and based on that, you can create a formula. Keeping in mind that a carbohydrate gives around 3 to 4 kilocalories per kilograms. Fat would give up to 9. Protein gives up to 4 kilocalories. Now, based on that, you calculate and mix it and then give it. So what all has to be taken into consideration? Because the patients are fasting for a long time, that is why you start off with TPN. When the patients are fasting for a long time, you end up thinking of refeeding syndrome. So your random blood glucose levels, glucose is very important. Hyperglycemia and hypoglycemia, very, very important factor. Now you give more calories, there is obviously more insulin that is produced in the body, and that ends up causing what? Steatosis. So liver function tests in TPN can be divided into 3 generally. One is cholestatic, one is just steatotic, and one is gallbladder sludge and gallbladder calculate. So how do you monitor? How do you monitor patients on TPN? So there are certain things which has to be done on baseline and then done daily till they stabilize, and then plan for next follow-up. There is something called as a home TPN also. Patients with short bowel syndrome, patients with cancer, patients who are unable to go for further therapy, they are sent home. They are sent home with parenteral nutrition. So for them, you have to call them for follow-up and then check. So the baseline ones which you have to be daily checked is electrolytes: sodium, potassium, magnesium, calcium, and phosphate. With respect to potassium, if you cannot monitor on a daily basis, you should make sure that potassium level is less than 10 milliequivalents per hour. Magnesium and calcium and phosphate. Now you can actually do a calcium and phosphate. You have to actually calculate calcium and phosphate and you add them up. 1 in milliequivalents and 1 in millimoles, and then the sum should be less than 45, because anything more than that, there is precipitation of calcium and phosphorus. You have to use the infection marker, CRP and T total counts, and baseline function test, liver function test has to be done. Now, what do you do on baseline on a weekly basis? Triglycerides and cholesterol. Triglycerides, the issue is you have to give fats, but you should withhold triglycerides. So a little bit of fat should not be given if your triglycerides are more than 400 milligrams per deciliter. But even if it is more than 400 milligrams per deciliter, you have to give at least 10% of the required fat as in IV fat emulsions, because if you withhold fat for more than a week, you end up having essential fatty acid deficiency. So baseline and 3 monthly would be zinc, copper, selenium, and manganese, along with ADE, B12, folate, vitamins. Now, with respect to TPN, I will plan a proper class and then probably let you know. But the answer of this question is LFT and triglyceride monitoring, that has to be done. The next question is pancreatic exocrine insufficiency diet consists of. Now, pancreatic exocrine insufficiency is basically when you don't have lipase. So medium chain triglycerides are the right answer, where it does not require any lipase. It can just get absorbed into the body. without chylomicrons formation. Now, that is the good thing. The bad thing is palatability is not very good. Basically, you use that, you can't use it for really cooking. You have to just put like drops of medium chain triglycerides into your food and then try to consume it. It is not very palatable. So within a non-alcoholic etiology, patients, especially in non-alcoholic etiology, patients of chronic pancreatitis should have small frequent meals. Fat restriction is no longer recommended, but with weight loss and patient with steatoria and weight loss, medium chain triglycerides may be useful to provide extra calories without causing steatoria. But it has got this not very good palatability. Palatability is quite poor in that. The next question, the cell responsible for the fibrosis in the cirrhosis of liver, that is stellate cells. Been told multiple times. Excuse me. The next question, CLD patients with UGI bleed, ascites, early encephalopathy. What stage of cirrhosis does this patient have? This question is actually a very basic question. It's basically a very conceptual question. So people have divided. Actually, it is probably in 2014. There's a guy called D'Amico who followed up around 20 years cirrhotic patients, around 400 cirrhotic patients for 20-25 years, and then he figured out what are the stages. So they start off stage 1, stage 2, stage 3, stage 4. And now we have added a stage 5 also into it. Now, when you talk about stage 1 and stage 2, there are compensated liver disease. Compensated liver disease basically nothing is outwardly visible. Stage 3 and 4 are decompensated liver disease. Decompensated liver disease, when you call decompensation, I've told you it's upper GI bleed, hepatic encephalopathy, ascites, anything is decompensated liver disease. So in this patient, you have got UGI bleed, decompensated, ascites, decompensated, early encephalopathy. So basically, you've got all the possible complications of liver disease, which is causing decompensation is there. So it has to be either stage 3 or stage 4, but considering the fact that there are all the decompensation features that is available, it has to be stage 4 disease. Now, what is means stage 1, stage 2, stage 3, and stage 4? Stage 1 is basically when there is no varices or no ascites, the diagnosis is only by ultrasound or CT. You must be getting an ultrasound done for another reason when you find the size of the liver being the same, but you will have nodular margins. Portal vein may be a little dilated, but there is no varices, there is no ascites. In stage 2, what happens? There can be varices, but there is no ascites. Grade 1 varices is also varices. Stage 2 is varices, no ascites. Stage 3 is ascites is there. Patient has developed ascites. Whether the patient has varices or not doesn't matter. Patient has ascites. Stage 4 is basically when the patient has an upper GI bleed. Upper GI bleed with or without ascites. Now, why do we have this compensated and decompensated liver disease? The reason why we have this thing is because of the mortality. You have to tell to the patient and the patient relatives that, see, what are you looking at? So basically, a death at 1 year for a stage 4 liver disease is around 60%, 50-60%. So in a case of ACLF or severe alcoholic hepatitis or a decompensated liver disease in stage 4 or stage 5 is basically an infection. It has got worse prognosis than even leukemia, lymphoma. 1 year, around 60%. So with that, we kind of come to a conclusion. These are the GI questions which we have got and the hepatology questions we have got. And like I mentioned before, these questions, most of the questions are easy. Some are tough, some are extremely tough. Now, how do we go about doing this? So now they have asked not only from Harrison, they have mentioned that it is an MD exit level. They have not mentioned the book. They have not mentioned only, they have not taken only from Harrison. Of course, they have taken from Harrison as well, but they have taken from other books as well. Now, getting a complete hold on a subject is near impossible because there are not only one subject, there are multiple subjects. You have got neurology, nephrology, you can go on and on. So getting a complete hold on all subjects is practically impossible. At one point of time, when these things were there before, when we did our DM, there was none of these resources that were available. So there was an information war that was going on, and thus we had to keep on getting whatever information we had. So we were at quite a bit of disadvantage then. But now if you actually plan to go the old school way, it is going to be quite difficult. So with that, let's see, it's a question, one question from amoebic colitis. I'm pretty, let's see what it is about. SK, for the SK, I'm not sure what, which question is this? May I? Do you have any idea regarding that? And another anonymous attendee has asked one question from amoebic colitis. Thank you. We will. Well, when will the NEET SS uploaded? I think they are in the pipeline. I think it should be. Oh, the one with the alcoholic patient and dupuytren's contracture. Okay. One second, SK. So basically, the palms had a very stiff thing with contracture. Okay, but let's go back to that question, and then 1 second. Let me just go back to that question, SK. Just a second, we will go back to that question. But yes, there is a definite terminology called alcoholic, and scleroderma will not come just like that. I'm sure the rheumatology will be able to help you out there. Dr. Rakesh is saying that I'm pretty sure this is a dupuytren's contracture only. Then what was the Abhinav, what was the treatment of HCV case? You have to give directly acting antivirals. Actually, if you ask me, that's first question. If you look at it, so if you look at this first question, a patient was incidentally found to have HCV RNA. The answer is directly acting antiviral, unless the last option, all the options instead of incorrect, if all the options are correct, you have to reassure the patient saying that, see, nothing is going to happen to you. Absolutely, there's no problem is going to happen if you manage to figure it out. You have to do a RNA PCR after 6 months to document cure. And obviously, the treatment is directly acting antiviral. So if the option D is all the options are correct, it is all the options are correct. So right now, because the option D is all the options are incorrect, we will go with a directly acting antiviral, and it will be sofosbuvir velpatasvir. That is for Abhinav. What would be an ideal way to prepare for this exam, sir? Okay, Manu Balaji Kiji. So like I mentioned, see, the question, the pattern of question is very clear. It has got a 70 to 75% of easy questions, around 20% tough questions, and 1 to 2% very, very tough questions. So obviously, we cannot miss the first part of it. The 75 to 80% has to be taken care. So that the easiest way to take care of these questions are basically concepts. Now, it is very difficult to remember one by one. I don't know, people may be able to remember, but whatever I have understood and what I have seen and done, you have a table, you can memorize it. Yes, you can memorize it, but you're talking about what? Nephrology, cardiology, neurology, which have got multiple tables. How are you going to remember all the tables? It's going to be very difficult. But whereas if you have a concept, one question, one tough question, for example, the valproate question. The valproate question is a tough question. And if somebody has read it, now that it'll be useful for him, definitely. But that is going to give you just one answer to that question. That is a statement you have read. So basically, it is up to your luck. Whereas the stages of cirrhosis, the HCV RNA, they are all conceptual based questions. So you have a concept. With the same concept, you can answer multiple questions. For example, autoimmune hepatitis. For diagnosis, there is no role for bilirubin and INR in hepatology. For diagnosis, prognosis, yes, it is very important. So when you see a bilirubin, which you have a concept on par, you can answer that question without really reading everything, without really knowing autoimmune hepatitis is the simplified scoring this thing. You can answer the question. Now, let me just see other questions. What was the answer for the TPN question is LFT and triglycerides. Rituximab prophylaxis duration is mentioned. Rituximab is a anti-CD20. It's a B-cell depletion agent. So if rituximab is per se given, it is 12 months. But if it is 6 to 12 months, you can continue 6 to 12 months as well. The question on ERCP, Satwat Micro, question on ERCP image is what is the ERCP image? So, like I said, so the options were, I believe, Ascarius, choledocholitis, pneumobili, and another one. So it has to be a choledocholitis. There cannot be it. Ascarius, like I mentioned, it has to be a tubular without any segmentations, tubular structure within the. Basically, what you see, what the cholangiogram image is actually an X-ray image. So you put the scope there, and then you put a dye in, and you see an X-ray image of that. So you're not going to get a very clear-cut Ascarius that is there. So if there is a tubular luminal structure that is there without any fenestration or any gaps in between, then you think of Ascarius. Otherwise, you will have to think of CBD calculi. And at your level, it has to be CBD calculi because already the question is tough. They are not going to ask a really question on top of tough question. Then next one would be how to prepare for ionolysis. Kindly repeat. What do you want to repeat? Yeah, accelerated Hep B schedule. Accelerated Hep B schedule, it's there. So that one is 0, 7, and 21 because there are no tables on that. So they have mentioned 1 year also. It has to be accelerated. So it is 0, 7, 21, and maybe 1 year. But 1 year doesn't fit the bill because it is never accelerated with respect to 1 year. You understand? Whenever you have the reason why we give accelerated vaccination is so that if you are going to generally accelerated hepatitis B is given in accordance with twin rigs, with when you're giving hepatitis A and hepatitis B. So this is generally given to people from the Western countries or from the developed countries where they come to a place of endemicity of hepatitis A and hepatitis B. So you have to finish off the vaccination before you reach there, and the immunity has to kick in as you reach there. So you cannot plan your trip 1 year from advance. You can imagine, no? So accelerated Hep B schedule should be 1 week and 3 weeks. Question back for INI CET gastroenterology. Yeah, we are working on it. We'll be giving it, I think. Alcoholic hepatitis treatment question, please. Okay, let me just go on to that. Alcoholic hepatitis. So there are two alcoholic hepatitis. One is the Lille score and one is management of severe alcoholic hepatitis. Well, both of it can be, the whole thing can be summarized in this specific. With respect to anonymous attendee, elaborate on that alcoholic hepatitis treatment question. PT wasn't given, only INR was given. Yes, I understand that, but if you look at delta PT, it's into 4.6. So when you look at PT in regular control, some labs have 13, some have 14, some labs have 12. Let us take it as 12. Now if a PT, if INR is around 2 point, let's say anything more than 1.5 to 2.5. If it is more than 1.5 or 2.5, generally, now this is something which I have come to know after seeing and doing a lot of discriminant functions. When INR is more than 2, that means your PT is much, the discriminant function is more than 32. The reason why PT is given and not INR, basically because every lab PT is different. So you have to take into the consideration the delta PT or PT control minus PT patient. So whenever, and obviously, and okay, the next one. What is the treatment for mild alcoholic hepatitis? Nothing. You treat them conservatively. It is only if there is severe alcoholic hepatitis, so you have to treat. So if your question is management of what do you do? So it has to be prednisone. And if INR is more than 2, it is severe alcoholic hepatitis. And if bilirubin is, see, it has to be more than 30. So any INR, let's say, and you have to multiply the delta INR 4.6, around 5. So anything more than the difference of 6 would easily make it up, easily going into it. So any INR, so if INR control, so the PT control is 12 and PT patient is 17, which would kind of make an INR of 1.4, 1.5, you have alcoholic hepatitis, severe alcoholic hepatitis. So if INR is more than 2, it has to be alcoholic hepatitis severe. Now I'm sure that it is difficult to do it at this level, agreed. So can you repeat the HCC management question again? Just a minute. Subarna Bhattacharjee, just 1 second. That would be here. Yes. So this is basically Barcelona Liver Clinic classification, BCLC. So this is one of the standardized algorithm which we follow for treatment for hepatocellular carcinoma. So in this BCLC classification, you take into consideration the liver disease and the character of the HCC. So based on the liver disease, put in a nutshell, if we have to remove the tumor, the liver has to be in a good condition. Otherwise, you have to transplant the liver. Now, if the tumor has gone beyond transplantation, that is basically the tumor has involved the vessels, then transplantation comes in, is being taken out. Now, between transplant and resection, we have the ablation. So that is a nutshell review of BCLC. Now, the same thing, HCC management question, this whole thing has been dealt with in depth in 2 or 3 sessions with respect to Marrow app actually. So the question was, there were 3 nodules and all the nodules were less than 3 centimeters. And one nodule was 3 centimeters. Now the patient did not have any other associated diseases as mentioned by the book. And it was mentioned to be a cirrhotic. So when you are a cirrhotic, this is out. This is, as of now, this is out. So you end up with DDLT. If there is an issue associated diseases like IHD where you cannot do a transplant, then you can think of ablation. Now, actually, the ablations have become so good and so precise that some of the ablations, so like microwave ablations and some TARE especially, or RFA, not TARE, RFA and microwave ablation, they actually can get a curative benefit. So question was for intern to start working in surgery department. Will we give twin rigs or Engerics? Good question. Why start in surgery department? No other places you get needle stick injury. Anyway, this is a question which is a very practical question. Now, if you look at it, all the medical colleges, I believe, most of the medical colleges at least, they are mandated to have hepatitis B antibodies before you start internship. So in that case, we generally give Engerics only, the normal routine, Engerics. This is India, so I would give Engerics only. So that is what our medical college and everything has been followed right now. And on the answer on alcoholic hepatitis, yes, if it is severe alcoholic hepatitis, it is prednisolone. It is not, there's nothing else in that. Monica, autoimmune hepatitis simplified score. Okay, we'll go there. In autoimmune hepatitis simplified score, 1 second, I'm sorry. Move on back. So like I said, see, autoimmune hepatitis simplified score is basically dependent on diagnosing autoimmune hepatitis, not for prognosticating autoimmune hepatitis. So in general, with respect to liver disease, for prognosticating, you use bilirubin and INR. For diagnosis, we do not use bilirubin and INR. So based on that itself, you can identify that there is no bilirubin involved in simplified scoring system, or for that matter, you do not have a bilirubin in the original scoring system, a large scoring system. Whether it is simplified or an original scoring system, you do not have a bilirubin. But the same thing. If for a prognostication of autoimmune hepatitis, you require bilirubin. So that is the difference. Does pentoxifylline equally effective as prednisolone? No, pentoxifylline is not effective. The trial, this is the trial STOP-R trial, which is, you should, if you're really interested in that, there's a trial called Stop Alcoholic Hepatitis, STOP-AH, STOP-R trial. It is a landmark. It is the landmark trial which said that the steroids has got much more efficacy than pentoxifylline, and that was the trial which took out pentoxifylline as being one of the standard of care for alcoholic hepatitis, and steroids took over. Still, pentoxifylline people give, because if it is severe alcoholic hepatitis and he has got ascites and GI bleed, but it is not recommended as per guidelines. Oh, there was a question on extrahepatic manifestation of HCV. Okay, I think I saw that question. In the extrahepatic manifestation of HCV, I think there was a detailed table that was given. So, well, the answer was, I think, B-cell Hodgkin's lymphoma. And obviously, there is no B-cell Hodgkin's lymphoma. There is B-cell non-Hodgkin's lymphoma. Hodgkin's lymphoma is a Hodgkin's lymphoma. So basically, the table has it. Actually, there is another question on cryoglobulinemia and HCV also. So that also is pretty much HCV patient presents with purpura, that is cryoglobulinemia. Then anything else? I am seeing the Q&A chat. Anything else? Is it possible to get, oh, good question. Is it possible to get anti-hepatitis B antibody in a fully vaccinated hepatitis B core antibody in a fully vaccinated and protected level of antibodies? Okay, you have gone into, okay, let's discuss this. It's an interesting question. Is it possible to get anti-Hep B core antibody? So if you get anti-Hep B core antibody, that means you have been infected in the past. Now, total anti-Hep B core antibody can be divided into IgG and IgM. IgM means you have been infected recently. IgG means you have been infected past before. Now, any patient who's had hepatitis B infection and it's been fully cured, hepatitis B infection, fully cured, what happens? You have got your total IgG antibody, total core antibodies being positive. Any doubts? I don't think so. Okay. And if they have recovered completely, what happened to the anti-HBs antibody? That will also be more than 10, more than 200, even more than 200. So, and then you've been vaccinated. What if the vaccination was later? So you can get. And protective level of antibodies is, protective level of antibodies just means more than 10. More than 100 and more than 10. More than 100 is what we actually, as a healthcare professional, we should, this thing. Anything more than 10 is acceptable as a protective level of antibodies. If you know your sero status very well, clearly. So yes, it is possible to get anti-Hep B core antibody in a fully vaccinated person. So I gave you a scenario there. Anything else? So with respect to anti-Hep B, I think the last revision class I had given a detailed discussion on. I did not want you guys to get confused on the serology and hepatitis B. So I had given a complete detailed discussion on that. So the simple answer: is it possible? Yes. How is it possible? I just told you. Another. Sjogren's can come. Yes. Is it possible to crack NEET SS gastro now if we start? Well, it is, as they say, nothing is impossible. Everything is possible, but you just have to bear in mind. Just one thing you have to bear in mind, that there are a lot of people who have been preparing for INISS, who have been preparing for a while now. So if you're starting now, you have to bridge that gap. Now that gap, if you can bridge, yes, you can get it. So that there is a gap, people can bridge it. It's not people can't bridge it, they can bridge it. But that requires commitment and consistency. If you're willing to do that, then you can. You remember that gap. Again and again, I'm telling you, concepts is more important. You can mug up how much ever you want, but mugging up will not take you as much as concepts will. Concepts can take you a lot of places. Just that you have to get the right concept. The problem with the concepts, only problem with the concepts is it is difficult to get the right concept. There will be a lot of, in a single line, there will be 2-3 concepts that are there. That you have to just have to be clear about. Anything else? Any other questions?
I think that's the last of it, sir.
All right. I hope you've benefited a little bit with this recall session. Well, I'm sure you'll benefit more with the app, with the classes that are there. Anyway, the take-home message in this with this exam is consistency has to be clear, and the exam pattern is similar. Tough, easy questions, some tough questions, some very tough questions. So based on that, you have to move forward. And nothing, like I said, nothing is impossible. You can easily do it. It's not very difficult, especially when the resources are available at your fingertips. It was not available like this. Now it is available. So definitely it's going to help you. And definitely, anonymous attendee, we are going to bridge that gap. I don't think we should bridge that gap. Okay. So with that, let me just sign off, unless you have got anything else. All right. Thank you.